A review of mid to late 20th century archival medical records reveals a period in clinical psychiatry defined by experimental polypharmacy. Polypharmacy is the concurrent use of multiple medications to treat a single condition, or, as was frequently the standard of the era, to manage the physiological consequences of a primary drug. In his historical text, A History of Psychiatry, From the Era of the Asylum to the Age of Prozac, 1997, medical historian Edward Shorter documents that the pharmacological revolution of the 1950s fundamentally shifted how physicians attempted to balance the chemical environment of the brain. During this time, the clinical approach was frequently defined by attempts to counteract the adverse effects of one substance with the primary actions of another. This methodology consistently led to iatrogenesis. In a clinical context, iatrogenesis refers to any illness, complication, or adverse effect caused directly by medical treatment. Historically, the management of psychiatric symptoms necessitated further chemical intervention to address the neurological fallout of the initial prescription, creating a cycle of escalating pharmaceutical dependency. In this deep dive, we are analyzing the historical trajectory of prescribing habits where the distinction between clinical treatment and societal compliance was significantly obscured. We will first examine the staggering pharmacological anomalies of the 1950s and 60s, specifically fixed-dose combinations that paired highly opposing drug classes in a single pill. We will analyze medications like Thora-Dex, which combined the potent antipsychotic Chlorpromazine with the central nervous system stimulant Dextroamphetamine. We will examine the clinical rationale behind Desbutal, a widely prescribed tablet that combined pharmaceutical methamphetamine with pentobarbital, a heavy sedative. Physicians of the era were effectively prescribing a simultaneous central nervous system stimulant and depressant, pulling the brain's neural pathways in two diametrically opposite directions at once. We will also look at the bizarre logic of Diprol, a 1950s medication that paired meprobamate, an early muscle relaxant and tranquilizer, with banactazine, an anticholinergic agent. It was marketed aggressively to physicians as a safe antidepressant, despite its profound risks of delirium and physiological dependency. The analysis will then track the precursor to the benzodiazepine era. The explosion of Miltown, meprobamate, in the 1950s, which set the cultural blueprint for the mass medicalization of stress. From there, we will dissect the subsequent rise of the benzodiazepines, examining the cultural dominance of diazepam, Valium, in the 1960s, and the transition to the high-potency alprazolam, Xanax era of the 1980s. From a neurobiological perspective, we will analyze their function as positive allosteric modulators. A positive allosteric modulator is a substance that does not fire a receptor on its own. Instead, it binds to a specific site on the GABA-A receptor and increases the efficiency of the brain's endogenous inhibitory signals. Most importantly, we will dissect the severe consequences of the widespread overprescribing of these compounds. We will track the resulting neurological kindling, a process where repeated exposure and withdrawal lead to increased neuronal sensitivity and a worsening of the underlying condition. To understand how these prescribing habits became systemic, we must examine the intersection of physician views, societal factors, and pharmaceutical marketing. As detailed by David Healy in The Creation of Psychopharmacology, 2002, mid-century marketing campaigns successfully framed standard environmental stress as a discrete chemical deficiency requiring a fixed-dose resolution. Societal demands for domestic compliance and workplace productivity heavily influenced physicians to prescribe these compounds as lifestyle management tools rather than strictly medical interventions. We are dissecting the history of these medications, the severe risks they posed, and the cultural landscape that allowed iatrogenic dependency to flourish under the guise of clinical treatment. To understand the clinical logic of the 1950s, we must first look at the medical crisis created by the introduction of the first antipsychotic, Chlorpromazine, marketed as Thorazine, in 1952. While Thorazine effectively emptied mid-century psychiatric wards by suppressing acute psychosis, it created a new, profoundly visible problem. Through its primary mechanism as a D2 receptor antagonist, blocking dopamine in the brain's mesolimbic and nigrostriatal pathways, it induced severe psychomotor slowing, apathy, and emotional blunting. Society and physicians alike demanded a solution. The cultural expectation of the 1950s prioritized visible productivity and domestic compliance. A patient who was no longer hallucinating but remained catatonic in a chair was not considered cured. In response, the pharmaceutical industry decided to chemically force the brain into a state of active compliance by pairing these heavy tranquilizers with potent central nervous system stimulants. The most jarring example of this was Thora-Dex, a fixed-dose tablet combining chlorpromazine with dextroamphetamine. From a neurochemical standpoint, Thora-Dex was a direct conflict of opposing forces. While the antipsychotic was aggressively blocking dopamine receptors, the dextroamphetamine was simultaneously forcing massive amounts of dopamine and norepinephrine into the synaptic cleft by reversing the direction of the dopamine transporter, DAT. The clinical result was a state of agitated sedation. The stimulant masked the profound drowsiness of the chlorpromazine, making the patient appear alert and functional. However, as documented in retrospective analyses of mid-century prescribing, this pharmacological push-pull frequently obscured the development of severe extrapyramidal symptoms, EPS. The stimulant-induced motor activity easily masked early signs of akathisia, a severe agonizing state of internal restlessness, and drug-induced Parkinsonism. Physicians, seeing a brightened patient, were given a false sense of security, entirely missing the neurological damage accumulating beneath the surface. If Thora-Dex was reserved for severe psychiatric intervention, Desbutal was the medication for the masses. Desbutal combined pharmaceutical methamphetamine with pentobarbital, a potent, short-acting barbiturate. To grasp the danger of Desbutal, we must understand the pharmacology of barbiturates. Pentobarbital acts on the GABA-A receptor, a primary inhibitory complex in the brain. However, unlike modern sedatives, barbiturates increase the duration of the chloride channel's opening. This creates a remarkably narrow therapeutic index, meaning the gap between a dose that relieves anxiety and a dose that causes fatal respiratory depression is perilously small. In her authoritative historical text, The Age of Anxiety, A History of America's Turbulent Affair with Tranquilizers, 2009, medical historian Andrea Tone details how drugs like Desbutal were aggressively marketed to everyday Americans. They were prescribed to businessmen for executive stress and to housewives for mild fatigue. The methamphetamine provided a sharp, euphoric lift for the workday, while the barbiturate was intended to smooth out the edges and prevent the inevitable stimulant crash. Instead, it created a devastating cycle of iatrogenic dependency. Patients experienced the intense, short-acting peak of the methamphetamine, followed hours later by the rebound anxiety and depressive crash of the barbiturate wearing off. This forced the patient to continuously redose just to maintain baseline functioning, trapping them in a violent, drug-induced oscillation between extreme nervous system arousal and dangerous central nervous system depression. This bizarre era of polypharmacy also produced Diprol, a tablet combining meprobamate with banactazine. Meprobamate was the active ingredient in Milltown, the first true blockbuster minor tranquilizer that fundamentally normalized the medicalization of stress. But Diprol went a step further. It combined this muscle-relaxing tranquilizer with banactazine, an anticholinergic agent. The clinical rationale was that the anticholinergic would act as an antidepressant to lift the patient's mood. In reality, combining a heavy central nervous system depressant with an agent that blocks acetylcholine frequently led to states of profound confusion, memory loss, and anticholinergic delirium. Physicians of the era genuinely believed they were practicing cutting-edge medicine. They viewed the brain as a simple chemical scale that could be mechanically balanced. It would take a decade of escalating dependency, soaring overdose rates, and public health hearings before the medical establishment fully recognized the catastrophic consequences of these pharmacological speedballs. This realization forced a desperate pivot away from barbiturates and stimulants, paving the way for a new, supposedly safer class of drugs that would ultimately define the next 30 years of American psychiatry: the benzodiazepines. By the early 1960s, the medical establishment found itself in a quiet panic. The cardiovascular collapse and overdose fatalities associated with barbiturates and pharmacological speedballs could no longer be ignored. The psychiatric field desperately needed a cleaner sedative, a compound that could suppress the nervous system without depressing the respiratory drive. The pharmaceutical industry responded with a class of drugs that would fundamentally alter the neurochemistry of the Western world: the benzodiazepines. While the first benzodiazepine, chlordiazepoxide, Librium, arrived in 1960, it was the 1963 FDA approval of diazepam, marketed as Valium, that triggered a prescribing tsunami. To understand why physicians handed out Valium with such unprecedented abandon, we must examine the neurobiology that provided them with a false sense of security. Unlike barbiturates, which act as direct agonists, benzodiazepines function strictly as positive allosteric modulators. When Valium crosses the blood-brain barrier, it binds to a highly specific, distinct site on the GABA-A receptor complex, an area now clinically referred to as the benzodiazepine binding site. Crucially, Valium does not open the chloride channel on its own. Instead, It increases the frequency of the channels opening only when the brain's endogenous GABA is already present. Contrast this with the barbiturates of the 1950s, which increased the duration of the channel opening and could force the channel to stay open even without GABA, leading to fatal respiratory failure. Because Valium merely amplified the brain's natural inhibitory signals rather than overriding them, it had a massive therapeutic index. It was incredibly difficult to induce a lethal overdose using Valium alone. Physicians looked at this safety profile and mistakenly equated safe from fatal overdose with biologically harmless. As medical historian David Hertzberg documents in his text, Happy Pills in America, From Milltown to Prozac, 2008, the marketing of Valium was a masterpiece of clinical gaslighting. Roche Pharmaceuticals did not market Valium for severe psychiatric disorders. They marketed it for the symptoms of modern existence. Advertisements in medical journals explicitly targeted the overwhelmed suburban housewife and the stressed corporate executive. They invented terms like psychic tension to pathologize everyday environmental stressors. The clinical consequences of this marketing were staggering. By 1978, Americans were consuming over 2.3 billion Valium tablets a year. It was the most prescribed drug in the Western world, the mother's little helper immortalized in pop culture. However, beneath this veneer of tranquility, a massive iatrogenic crisis was quietly compounding. Because Valium has a remarkably long half-life, its active metabolite, desmethyldiazepam, can remain in the bloodstream for up to 100 hours. Patients taking the drug daily were essentially in a state of permanent accumulating sedation. More insidiously, the medical establishment fundamentally misunderstood the brain's capacity for neuroadaptation. When a patient takes a positive allosteric modulator continuously, the brain attempts to restore homeostasis through receptor downregulation. The brain physically reduces the number of active GABA receptors and decreases their sensitivity. When a patient attempted to stop taking Valium, they didn't just return to their baseline anxiety. They plunged into a state of profound chemical deficit. This triggered the benzodiazepine withdrawal syndrome. Because the inhibitory GABA system was downregulated, the excitatory glutamate system ran unchecked. Patients experienced agonizing rebound anxiety, severe insomnia, muscle fasciculations, and, in severe cases, depersonalization and withdrawal seizures. Because physicians in the late 60s and 70s were largely uneducated on the mechanics of receptor downregulation, they routinely misinterpreted this severe withdrawal state as the return of the underlying illness. The clinical response was almost universally to put the patient back on the drug, often at a higher dose. The Valium empire proved that a drug does not need to be acutely lethal to be profoundly destructive. The psychiatric field had successfully medicalized the human condition, replacing resilience and environmental modification with chemical dependency. But as the 1970s closed, public hearings and tightening regulations forced Valium off its throne. The pharmaceutical industry, however, already had a successor waiting in the wings, a drug that was vastly more potent, featured a terrifyingly short half-life, and was designed to hit the brain like a lightning bolt. As the 1970s concluded, the medical community was increasingly aware of the dependency issues associated with long-acting benzodiazepines like diazepam. In 1981, the pharmaceutical industry shifted its approach when Upjohn secured FDA approval for alprazolam, marketed as Xanax. From a neurobiological standpoint, alprazolam is structurally distinct from its predecessors. It is a triazolobenzodiazepine. The addition of a triazole ring to its chemical structure makes the molecule highly lipophilic. This structural modification allows it to cross the blood-brain barrier and penetrate the central nervous system much faster than older benzodiazepines. It rapidly binds to the GABA-A receptor with high affinity, inducing anxiolytic effects within minutes. However, the rapid clinical dominance of alprazolam in the 1980s was not driven by pharmacology alone. It was the result of highly targeted marketing that capitalized on shifting diagnostic frameworks. In 1980, the American Psychiatric Association published the DSM-3, which formally codified panic disorder as a distinct clinical diagnosis. Upjohn aggressively positioned alprazolam as the targeted primary treatment for this newly categorized condition. The marketing campaigns found in 1980s medical journals were distinct from the stressed housewife ads of the Valium era. Upjohn frequently marketed Xanax as an adjunct to psychotherapy. Advertisements suggested that patients who were blocked or unresponsive in traditional talk therapy could be chemically stabilized with alprazolam, allowing therapeutic breakthroughs. This strategy successfully normalized the prescribing of high-potency sedatives by general practitioners and psychologists, blurring the lines between pharmacological and psychological intervention. The clinical data supporting these campaigns was heavily curated. During the initial 14-week efficacy trials funded by Upjohn, patients on alprazolam showed significant improvement at the 4-week mark compared to the placebo group. The marketing heavily emphasized these short-term results. However, by the 8th week, the placebo group continued to improve while the drug-exposed group stagnated. More critically, when patients were tapered off the drug at the end of the trial, a significant percentage experienced profound deterioration, suffering rebound panic more severe than their initial baseline. This rebound effect was driven directly by the drug's pharmacokinetic profile. Alprazolam has an exceptionally short half-life, often clearing the body in 11 to 15 hours. This rapid CNS penetrance combined with a rapid clearance rate created a distinct form of iatrogenic dependency. Because the drug was metabolized quickly, patients frequently experienced interdose withdrawal. Just 4 to 6 hours after a dose, as receptor occupancy dropped, patients would experience acute rebound anxiety. In clinical practice, this chemically induced withdrawal was consistently misidentified as the underlying panic disorder breaking through. The standard clinical response was to increase dose frequency, often resulting in prescriptions of up to 4 doses a day to maintain baseline stability. The late 1980s and early 1990s also marked the return of the mid-century polypharmacy model. With the introduction of the first selective serotonin reuptake inhibitors, SSRIs, such as fluoxetine, Prozac, physicians encountered a new set of clinical challenges. While SSRIs were highly effective, they frequently caused initial activating side effects, including jitteriness, insomnia, and akathisia during the titration phase. The clinical solution mirrored the logic of the 1950s Thora-Dex era. Physicians began cross-prescribing alprazolam alongside the SSRI. The antidepressant was prescribed to elevate serotonin signaling, while the high-potency triazolobenzodiazepine was utilized to neurologically mask the activating side effects. The medical field was, once again, deploying a secondary dependency-forming compound to manage the physiological fallout of the primary intervention. When reviewing this timeline, from the fixed-dose combination pills of the 1950s to the mass prescribing of long-acting diazepam, and finally the high-affinity, short half-life era of alprazolam, a definitive clinical pattern emerges. For half a century, the standard of care was heavily reliant on chemical balancing. Potent central nervous system modifiers were deployed not only to treat severe pathology, but to manage environmental stress, with the resulting neurological damage frequently masked by further medication. The transition toward highly targeted, circuit-specific psychopharmacology was a necessary clinical evolution, driven by the accumulating data of a 50-year iatrogenic crisis. This has been an analysis of the clinical history of the mind. Subscribe for more medical history.